staining here. So this stain is nothing but it is the Alcian blue. Very good, very good. Specifically Alcian blue. So what is the specialty of this Alcian blue? This Alcian blue stains the acidic mucin. Okay, this Alcian blue stains the acidic mucin at a pH of 2.5. At a pH of 2.5. So normally this esophageal mucosa will not have acidic mucin. So if you can demonstrate the acidic mucin with the help of this Alcian blue, you can appreciate here all these blue vacuoles are nothing but they are the goblet cells which are containing the acidic mucin. Goblet cells which are containing the acidic mucin. So this is actually a diagnostic of Barrett's esophagus. Now let me, can you please answer? What is this Barrett's esophagus? Why we have to bother about this Barrett's esophagus? What is that? Does it predispose to? Yes, Barrett's esophagus predisposes to. What is the risk factor? Like squamous metaplasia predisposes to squamous cell carcinoma in smokers. Similarly, Barrett's esophagus is a predisposing factor for. Yes, please remember, this is a very important thing. Barrett's esophagus can predispose to adenocarcinoma of the esophagus. Okay, adenocarcinoma of the esophagus. And here, note down another important question. The most common esophageal cancer, it is a squamous cell carcinoma. The most common esophageal cancer in the upper 1/3 of the esophagus, middle 1/3 of the esophagus, both it is squamous cell carcinoma. But if the examiner specifically asks you, what is the most common esophageal cancer at the lower end of the esophagus? The answer should be adenocarcinoma of the esophagus. It is because Barrett's esophagus is commonly occurs in the lower 1/3 of the esophagus. So adenocarcinoma is the commonest cancer in the lower 1/3 of the esophagus. This point also you have to remember. Okay. So moving on to the next, coming on to the other adaptations. Like a hypertrophy. What is hypertrophy? Hypertrophy is the increase in the size of a organ, tissue or an organ. Okay, hyperplasia is increase in the number. Okay, hyperplasia is increase in the number. So the dividing cells, continuously dividing cells will go in for hyperplasia, whereas cardiac muscle, remember this cardiac muscle, skeletal muscle, these muscles actually have stopped the cell division. So there you will be getting hypertrophy. Physiological hypertrophy and hyperplasia can occur during pregnancy. And this tabular column actually you have to remember, because please remember, pregnant uterus undergoes both hypertrophy as well as a hyperplasia. But if you have to choose only one option, you have to choose hypertrophy. That means both the hypertrophy as well as the hyperplasia occurs, but hypertrophy is predominant one compared to hyperplasia. Okay, so all of the following can be seen in pregnant uterus. Yes, hypertrophy right, hyperplasia right. But if you have to choose which of the following is seen in pregnant uterus, then you have to choose hypertrophy. Then pregnant breast during puberty and pregnancy undergoes both the hypertrophy as well as a hyperplasia. But please remember, breast during lactation. Okay, breast during lactation, it undergoes only hypertrophy and not hyperplasia. Yes, breast during lactation undergoes only hypertrophy and not hyperplasia. Okay, this is a very important place where the examiners will try to catch us. Okay, so hyperplasia can be a predisposing factor for even malignancy like endometrial hyperplasia. Yes, that is called as pathological hyperplasia, endometrial hyperplasia, which is estrogen responsive one. Okay, estrogen stimulant one. So endometrial hyperplasia can predispose to endometrial cancer. Okay, remember that. And atrophy, all of you know that atrophy is the decrease in the size of an organ or a tissue. Okay, so atrophy, hypertrophy, hyperplasia, and metaplasia are called the cellular adaptations. Okay, now let us move on to the next question. A 60-year-old male was admitted with a severe crushing substernal chest pain. Okay, so the patient is having a crushing type of chest pain and it is a substernal in location. Analysis of the cardiac markers and ECG finding confirms the diagnosis of acute MI. Yes, they have given us the diagnosis and the patient is subsequently expiring. Okay. Now, what happens now after this after this death, we are going in autopsy. So in the autopsy, when you are examining the heart, actually you can see the left ventricle. This change is there. Okay, this change is there. So now carefully look at this change. And now see the question. The histologic examination of the heart muscle is likely to reveal what? So the examiner is asking you. So histologically examination, what you can expect in these areas is. So grossly you can see here, this is a fleshy muscle and this is the viable one. That is a viable one. And in the background of my MI, if they are give the examiner is giving you this kind of muscle with some shrunken. See this, how it is appearing. So this is somewhat shrunken and gray white in appearance. No, so this is the area of the infarct. Okay, so this is the area of the infarct. So myocardial infarction, the area of the infarct will be appearing gray, white, and shrunken. So what is the type of necrosis? So in the option itself, it says that the examiner is asking you what is the type of necrosis. So what is the type of necrosis you will see in MI? Yes, it is the coagulative necrosis. Very good, very good. Coagulative necrosis. So let us quickly recap about all the types of necrosis within a short span, like coagulative necrosis. In which organs you can get coagulative necrosis? Please remember, coagulative necrosis you can get in solid organs. Solid organs. The commonest organs are heart, kidney, and spleen. Heart, kidney, and spleen, or the organs in which you can get coagulative necrosis. And so it is the organs usually with a single blood supply. So what is the histological appearance you can get in coagulative necrosis? That is the tissue architecture will be maintained. That is the tissue outer architecture. Say for example, see here. This is actually a section from histology of an infarcted kidney. So you can see this. This is the glomerulus. That is the outer architecture. Yeah, it resembles like a glomerulus. Yeah, it's looking like a glomerulus. And these are all the tubules. That is, the outer architecture is maintained. But if you carefully see, you are not able to see the inner nuclear details. Okay, you are not able to see whether the nucleus is there, how the cytoplasm is there, what is this. So nothing is there. So you can see only the outer architecture, but the inner nuclear details are lost. Yes. What is this type of appearance is called as? Only the outer architecture is maintained and the inner nuclear detail, nothing is being seen. What is this appearance in coagulative necrosis? It is called as, commonly called as, yes. What appearance? This appearance is called as tombstone appearance. Tombstone appearance. Yes, very good. Tombstone appearance. Tombstone appearance. And where else you will see tombstone appearance in pathology? Where else you have heard of this tombstone? Row of tombstone appearance? Row of tombstone appearance? Yes. Pemphigus, to be very specific, Pemphigus vulgaris. Okay, Pemphigus vulgaris also you will be getting row of tombstone appearance. Then that is about the coagulative necrosis. Then coming to here, if you hear the word brain and necrosis, you have to think of liquefactive necrosis. Yes. In the brain tissue, actually, it is rich in hydrolytic enzymes. Brain tissue is rich in hydrolytic enzymes. So the type of necrosis which occurs in the brain results in the hydrolysis of the tissue. So it is the liquefactive necrosis, which, yeah, other name for liquefactive necrosis is colliquative necrosis. Very good, very good. So this, and also you can see here, the necrosed part appears converting into a cystic cavity, and you can see the liquefaction. Okay, liquefaction. And the other areas where you can get liquefactive necrosis is pus and the abscess cavities. Abscess. So abscess, you will get collection of the pus, no? So there you will be getting the liquefactive necrosis. The tissue undergoes necrosis where it gets liquefied. Okay. And the next thing, if you in the histology, you can in the gross, if you can see, this is a lung. Yeah, this is a lung, the alveolar spaces, all this thing. And grossly, if you can see this cheesy appearance. Yes, very good. This kind of cheesy, white cheesy appearance in the gross, in a lung or lymph node. Students, please think of your caseous necrosis. Think of your caseous necrosis. Hmm? So caseous necrosis, if you hear the word simultaneously, you will be hearing of tuberculosis, and also you will be getting infections like histoplasmosis, coccidioidomycosis. So all these things also you will be remembering simultaneously. You will be remembering simultaneously. TB, histoplasmosis, coccidioidomycosis. So histologically, you can see caseous necrosis with granuloma. The caseous necrosis, you will not see any outer architecture or nothing. What you will be seeing is you will be seeing only eosinophilic amorphous material. Eosinophilic amorphous material. Eosinophilic amorphous material as a caseous necrosis. Yes. And you will be getting the granuloma also. Granuloma also. Yes. Then what is this type of necrosis? Which is seen in the tissues rich in adipose tissue, which is rich in adipose cells. And this is called as the fat necrosis, fat necrosis. So this is a favorite picture of your image of your examiners where you can get, this is actually a omental tissue. And in the omental tissue, you can see this whitish deposits. Yes. Can you see whitish gritty deposits? So what are these things? In fat necrosis, yes, now we are talking about fat necrosis. And in fat necrosis, if you can see in a fat-rich organ like a omentum, you can see this white structures. What are these things? These are all the chalky. These are called as the chalky white deposits. These deposits are called as chalky white deposits. So chalky white deposits are nothing but actually this is a fat necrosis, no? So usually fat necrosis where you will see in acute pancreatitis, you will be seeing. So in acute pancreatitis, where there is an inflammation of the parenchyma, pancreatic parenchyma, and liberation of this lipase, amylase. So all these enzymes will be liberated. Yes. So all these enzymes will be liberated and they will start digesting the fat-rich areas, that is the omental tissue and peritoneal pad of fat. So they will be in this process, they will be releasing the fatty acids. Yes. Fatty acids. So that fatty acids plus calcium, the fatty acids, liberated fatty acids plus the calcium will be resulting in a process of saponification. Okay, resulting in a process of saponification. So this saponification actually in the gross, they will be looking like this chalky white deposits. So chalky white deposits characteristic of fat necrosis. Yes, fat necrosis. And so what is this type of necrosis? Yes, this is actually from this picture. This is a very classical picture, and the examiner has given you this number of times. And see this. This is the blood vessel, and this is the RBC. Yes, very good, very good. RBC, and here in this blood vessel, if you can see, this a deposition of how you can demonstrate, how you like describe this phenomenon. You can see bright eosinophilic. See this bright eosinophilic. Okay, bright eosinophilic material which is deposited on the vessel wall, that is none other than this our fibrinoid necrosis. Yes, fibrinoid necrosis. The name says that fibrinoid, that means what? Fibrin like. But please remember students, fibrinoid, fibrin like, though the name says that actually it is the deposition of the fibrin itself. Yes, so fibrinoid necrosis, which conditions you will be seeing fibrinoid necrosis? You will be seeing mainly in vasculitis. Vasculitis, yes. Vasculitis, inflammation of the vessels, where there is an antigen, especially in cases like SLE, where there is an antigen antibody response is there, and these antigen antibody complexes will be deposited on the vessel wall. They cause damage to the vessel, and there will be leaking of the fibrin, which will be deposited in the vessel wall. So vasculitis is PAN, polyarteritis nodosa are commonly seen. And rheumatic heart disease, this Ashcroft bodies. So in the Ashcroft bodies also, you can see this fibrinoid necrosis. So these are all the areas you can get fibrinoid necrosis. Yes. And please remember, very important point to differentiate this apoptosis and necrosis is, in necrosis, there will be inflammation, and apoptosis, there will not be any inflammation. Why? Because necrosis, whether it is a caseous or coagulative or fibrinoid fat or liquefactive anywhere, so there will be a necrosis will be super added by, like always accompanied by inflammation, because the cell membrane will be damaged. Okay, but in our apoptosis, the cell membrane is intact. So in apoptosis, inflammation will not be there. The cellular contents will not be leaked out. So there will not be inflammation. But in necrosis, there will be leaking of the cellular contents through the damaged cell membrane. There will be an inflammation. There will be an inflammation. Okay. So moving on to the next question. The histopathological sections of pneumonectomy specimen of a 60-year-old male patient who presented with features of squamous cell carcinoma of lung is shown. Which of the following pigment can be seen as an associated finding in pneumonectomy specimen? Pneumonectomy specimen. Yes. So this is actually a case of a pneumonectomy. That is, they have done the removed the lobe of the lung. Why they have removed? Because the patient is having a squamous cell carcinoma. So they are removing the lung. So in the additional to that squamous cell carcinoma findings, you are seeing what you are seeing is you are seeing this deposition of black color pigments. Black color pigments. So black color pigments are deposited in the lung. First thing you have to think of this anthracotic pigment. Okay, these are nothing but the inhaled carbon particles. Yes. So day to day we are inhaling a lot of carbon particles. So those carbon particles are deposited in the lung. You call that as anthracotic pigment. Okay, anthracotic pigment. Yes. So now I'll take this opportunity to revise your all the other pigments and the special stains. Okay. So because the special stains is very important. So let us quickly revise about the special stains and the pigments. So what is this special stain? If I say that this is a case of a liver, and in a case of a thalassemia patient, you do a liver biopsy. You do a liver biopsy. Why you are doing liver biopsy? To assess the iron overload. Yes. So iron overload. So you can see this, that hemosiderin is deposited in the liver parenchyma, and they are seeing as a blue granule. So what is this stain? What is this stain? Yes, very good. What is the stain? This is a Pearl's Prussian blue. This is the Pearl's Prussian blue. Pearl's Prussian blue, many places you can see, even in hemochromatosis and even in MDS, myelodysplastic syndrome, also you will be doing this to highlight your ring sideroblast and also your iron deficiency anemia to demonstrate that whether the iron stores are there or not. So in those cases also, you will be doing this Pearl's Prussian blue, one of the commonest stain, okay, for this hemosiderin. Now let's quickly go through this table column. Mason trichrome. Yes, Mason trichrome is the special stain for collagen fibers. Okay, the collagen fibers will be appearing blue in color. Okay, collagen fibers will be appearing blue in color. Mason trichrome. In myocardial infarction, old infarcts will be replaced by the collagen scar. No, so that it will be Mason trichrome blue in color. Cirrhosis of liver. So cirrhosis, the liver is replaced by fibrosis. Fibrous septa will be there. No, so if you do Mason trichrome, that area will be appearing as a green, blue in color. So Mason trichrome for collagen. Yes, von von Giesen stain. Elastic fibers. Okay, so these elastic fibers will be highlighted black in color. Okay, so especially in Marfan syndrome, when you want to demonstrate that cystic medial degeneration, that is in dissecting aneurysm, you must have heard, like in dissecting aneurysm, the media will be very weak, tunica media, the elastic fibers will be lost or degenerated. So you want to highlight the degenerated elastic fibers, you do a von Giesen stain. So whenever we are learning this special stains, we have to always keep in mind what clinical scenario they can give in the back of this interpretation. Okay, so they can give you a clinical scenario, and on interpretation they can give you the special stains. Okay, so we can expect the questions only based on this kind of integration things, sort of things. And silver methenamine stain. Reticulin will be it will be highlighting the reticulin. So reticulin fibers are increased in case of fibrosis, marrow fibrosis, bone marrow fibrosis. Yes, myelofibrosis. Have you heard of myelofibrosis? That is the fibrosis of the bone marrow. So those you want to demonstrate the increased reticulin fibers, you use silver methenamine. Yes, all of our favorite oil red O. So if you hear the word O, think of fat. Okay, fat droplet. Okay, fat droplet. Oh, Sudan black. Okay, all this for fat. And then muscles, the special stain is Mallory muscle, PTAH stain. And for fibrin, for to highlight the fibrin, MSB. MSB is nothing but Martius scarlet blue. Okay, and one of the commonest stains which every one of us heard is PAS, that is per iodic acid ship. Per iodic, iodine is there. Okay, so this will be highlighting your glycogen and even the glycogen and even your basement membrane. Yes, in kidney biopsies, kidney biopsies, when they are when they want to highlight the basement membrane, yes, you will say basement membrane thickening, basement membrane thickening. How will you highlight the basement membrane thickening? So PAS stain will help you. Okay, and it also stains the neutral mucin. Remember, acidic mucin is stained by Alchian blue and musicarmine. Yes, and but your neutral mucin is stained by your PAS. Yes, all of us know that the Congo red stains for amyloid and one cosa and alizarin red both are used to stain calcium. But the subtle difference is there. One cosa is the most commonly used stain, and alizarin red is the most specific for the calcium. Yes, this we just saw pearls Prussian blue for iron and Mason Fontana. Okay, Fontana. Don't confuse with the Mason trichrome. Mason trichrome is for collagen, whereas Mason Fontana is for actually melanin. Melanin. Okay, then copper. Okay, in Wilson's disease. Yes, in Wilson's disease, when there is a copper overload, copper deposition in the liver, so you do the special stains or sin and modified rhodamine. Okay, modified rhodamine. So please remember Austen copper. Okay, and modified rhodamine copper. So please remember. And toluidine blue. This is a question which was asked in your last exams. Toluidine blue is a special stain for mast cells. Yes, mast cells. What are the other special stains you will remember? You will be remembering tryptase. Yes, mast cells are the tryptase and other markers CD117 and CD30. These are all the recent updates. Okay, these are the recent updates where the examiner can ask. Yes, you are right. CD117, the same CD117, that is the C kit you have heard of in just gastrointestinal stromal tumor. The same CD117 will also highlight the mast cell. Okay, will also highlight the mast cell. CD30, tryptase, toluidine blue, all are special stains for the mast cells. Okay, then GMS and PAS can be used to highlight the fungal elements. And this Shikata arsine stain, that is a hepatitis B antigen. Yes, do you remember any morphology in the liver? Hepatocytes, chronic hepatitis B infection. What change you will be getting in hepatocytes? Chronic hepatitis B infection. How the hepatocytes will look? Chronic hepatitis B infection, how the liver cells will look like. What is the classical terminology they will be using is? Yes, that is the ground glass hepatocytes. Yes, have you heard of this? Ground glass hepatocytes. So in chronic hepatitis B infection, the liver cells will look like a ground glass, and that will be highlighted by this Shikata arsine stain. And why it is looking like a ground glass? Because it contains a lot of this hepatitis B virus molecules. Okay, hepatitis virus B antigens. Okay. Then musicarmine and India ink for Cryptococcus, Wathin-Starry for spirochetes, and calcofluor white for Acanthamoeba, Zeal-Nielsen and Kinyon stain for acid-fast organisms, and the Machola stain for rickettsia. Yes, in the microbiology also you will be learning this. Okay, so just a quick recap of your special stains. Now moving on to the next question. A 4-year-old child presented with a history of recurrent middle ear infections and pneumonia requiring hospitalizations and mucosal infections. So the child is having a repeated history of infections. And what is the thing is the microscopic examination of the infected lesion. The lesions per se is showing few neutrophils. In the lesions, there are few neutrophils, but in the periphery, that means what? If you take a blood, CBC, okay, complete blood count, if you take, there are a lot of neutrophils. So total count is increased. The WBC total count is increased, and that is actually predominantly by the neutrophils. So neutrophilic leukocytosis is there. But if you see in the site of injury, site of infection, the neutrophils are very less. The neutrophils are very less. So they are asking you what is the child's increased susceptibility to infections? Why the child is having a repeated infections? Yes, anybody? Yes, very good, very good. So it is the defect in the leukocyte adhesion, defect in the leukocyte adhesion. Like, let us quickly recap about the cellular events of inflammation, which will help us to understand this disease better. So normally there is an axial blood flow. Yes, normally there is an axial blood flow in a blood vessel. What is mean by axial blood flow? That is in the blood vessel, in the central stream of the blood vessels, there will be WBCs and the cellular component will be flowing. The cellular component will be flowing in the central stream. Whereas in the touching your blood vessels, there will be a fluid part. Fluid part. So the fluid part will be propelling the cellular components. So what happens when there is any infection? So body will get a stimulus that there is an infection, there is an enemy which is standing outside and waiting to kill the origin of the host. So what will happen? The cells will slowly marginate. Previously, they are in the center, no? So they will slowly marginate. So the next step is margination. So after margination, what happens? The cell keeps on rolling. Okay, the cell keeps on rolling into the blood vessel wall. And after rolling, like imagine you put a ball. Okay, you put a ball in a ground. So what will happen? The ball will touch the ground, touch the ground, touch the ground, and then it will be that is the rolling. And after that, it will be keep on and it will be rolling, and it on one place it will be firmly adherent to one place. So similar thing happens. So the cell keep on rolling on the blood vessel wall, and at one place it firmly adheres. It firmly adheres on the vessel wall. After the adhesion, what happens? It is coming out. Okay, so it is coming out. So why it is coming out? Because the enemy is somewhere out. The enemy, that is a microbe. The microbe is somewhere out. So the cell has come out. The cell has come out. These are only soldiers. So the soldiers have come out. The soldiers from various areas are recruited to the site of injury. How they will move out? This process is called as chemotaxis. What is chemotaxis? The cell has come out of the blood vessel, but it has to move to the site of war. That is where the microbial agent is sitting. So the microbial agent, where it is sitting, it will be liberating some chemical mediators. So driven by the chemical mediators, attracted by these chemical mediators, the cell will move into the direction of the microbial agent. So this process is called as chemotaxis. Chemo, attracted by a chemical gradient, it moves to the site of injury. So after chemotaxis, what happens? After chemotaxis, there is phagocytosis occurs. There is phagocytosis occurs. Okay. So these are all the steps. So what will happen? This rolling, adhesion, all these things are mediated by chemical substances. Yes, chemical substances. See here, for rolling to occur, you need two molecules rolling. That's WBC as well as the vessel wall endothelium. There is a connection between the WBC and see this. There is a WBC, and this WBC has some protein called as sialyl-Lewis protein. The WBC has a protein called the sialyl-Lewis protein, and the endothelium expresses E-selectin. Endothelium expresses E-selectin. So there is a touch. There is a touch between the E-selectin as well as your sialyl-Lewis molecule. There is a sialyl-Lewis molecule. So this interaction, sialyl-Lewis, which is present on the WBC, and the E-selectin, which is present on the endothelium, the transient touch results in the rolling. Then what happens? Adhesion. So adhesion means there is a firm touch between the WBC and the endothelium. For adhesion to occur properly, you need integrins on the surface of the WBC. You need integrins on the surface of the WBC, and the blood vessel. And the blood vessel, it expresses a ICAM1. ICAM1 is nothing but integrin ligand molecule, intracellular adhesion molecule, intracellular adhesion molecule. So there will be a adhesion, there will be an interaction between the integrins which is present on the WBC as well as the ICAM which is expressed on the endothelium. After the adhesion, you know that there is a e-migration, and please remember last NEET exam, it was asked like INICET, it was asked like what is a molecule which is responsible for the e-migration, diapedesis. Yes, e-migration, otherwise called as diapedesis, that is the exit of the WBC from the blood vessel. So remember, PCAM1 or CD31, PCAM1 or CD31 is responsible for the is expressed both on the endothelium as well as on the WBC surface, and this is responsible for the exit of the cell. Okay, so why we are talking all these things? So if all these molecules to come for a cell to come out of the blood vessel, all these molecules are needed. Okay, so if these molecules are not there, that is if there is a defect in the selectin, if there is a defect in the xylate lubis, if there is a defect in the integrins, so what will happen? What will happen? The cell cannot come out. The cell cannot come out of the blood vessel. So what will happen when there is a bacterial infection? The body will get a stimulus. Okay, there is a bacterial infection is there. So body will keep on producing lot of WBC. Body will keep on producing lot of WBC. So the neutrophilic leukocytosis, yes, the WBC count will go high. Yes, in the periphery, in the blood vessel, the body is getting a signal. So body will be producing lot of WBC, increased leukocytosis. Yes, that will be full of neutrophils. But though, what is the use? Those neutrophils cannot come out of the blood vessel. So they cannot come out of the blood vessel. So at the site of injury, where they should be actually there, because the selectin integrins are not there, the cells cannot come out. So at the site of injury, there are less WBC. So if you carefully see here, in our question, there is a marked neutrophilic leukocytosis, but at the site of injury, there is infected lesion show very few neutrophils. This characteristically tells you that there is a defect in the leukocyte adhesion. There is a defect in the leukocyte adhesion. Yes. So after this, what I told is that it will be a phagocytosis. Yes. So phagocytosis में क्या होता है? Like what happens in the phagocytosis? So इनके पारंगा. So level when a cell is undergoing phagocytosis, when a macrophage is engulfed, the macrophage is engulfed and it want to kill the bacteria, so it will be consuming lot of oxygen. That is called as oxygen burst. Yes, that is called as oxygen burst. What happens in oxygen burst? That is inside the macrophage in the phagocytic vacuole. Yes, macrophage has now engulfed the bacteria. Now the bacteria is inside the phagocytic vacuole of the macrophage. So the macrophage is engulfing lot of oxygen. So this oxygen, see this oxygen will be converted with the help of an enzyme called as NADPH oxidase. With the help of an enzyme called as NADPH oxidase, it will be getting converted into superoxide. Yes, superoxide. Then variety of other reactions occurs, like superoxide will be converted into hydrogen peroxide, and hydrogen peroxide will be converted into hydroxyl ions. Then you have neutrophils, no, lot of granules will be there, myeloperoxidase. Yes, myeloperoxidase. These myeloperoxidase granules will be converting this into hypochlorite ions. So listen carefully. What is needed for this hypochlorite ion formation? This is why you need a hypochlorite ion, because this hypochlorite ion is the most potent bactericidal agent. This free radical only is going to kill the bacteria. Yes. So hypochlorite ions are not there. That means bacteria will not be killed. So imagine if NADPH oxidase is not there, the respiratory burst can give you a lot of oxygen, but those oxygen will not be converted into superoxide, because to convert into superoxide, you need NADPH oxidase. So in the absence of NADPH oxidase, there will not be any free radical formation. So the bacteria will not be killed. So what is the disease you will be getting in which NADPH oxidase, if it is not there? What is the disease? Yes, you heard of the disease? What is the disease? If NADPH oxidase, if it is not there. If any bacterial agent is, or any injurious agent, if it is not being eliminated by the body, yes, you are right. It is there, then you will be getting a chronic granulomatous disease. So if any injurious agent, if it is not being able to killed by the bacteria, or anything, the body responses to giving by a granuloma response, a granuloma. So you will be getting chronic granulomatous disease. The enzyme deficient is NADPH oxidase, NADPH oxidase. And what is the famous test which you don't know in chronic granulomatous disease? Yes, if you see this image, what test comes to your mind? Yes, what is this NBT test? What is this NBT? Yes, NBT stands for nitro blue tetrazolium test. Nitro blue tetrazolium test. Yes. So what is this nitro blue tetrazolium test? This nitro blue tetrazolium test, actually, what does it means now? This NBT, that is nitro blue tetrazolium, in the presence of this oxidase, in the presence of this NADPH oxidase, the nitro blue tetrazolium will be converted into a compound called as formazole. Formazole. Actually, this formazole will be blue in color. Blue in color. So this nitro blue tetrazolium will be converted into formazole in the presence of NADPH oxidase. So normal person. So I have given you two pictures. One is showing the neutrophils with both are treated with nitro blue tetrazolium. One is not showing any color change, but the other is showing a blue color change. Blue color change. Now tell me who is having a chronic granulomatous disease? One or two? Who is having chronic granulomatous disease? One or two? Which patient is having? Patient number one or patient number two? If the patient is having chronic granulomatous disease means there will not be NADPH oxidase, then NBT will not be converted into formazole, and NBT will be negative. Blue color will not be formed. Very good. Blue color will not be formed. So NBT, if it is negative, that means what? There is no NADPH oxidase. No NADPH oxidase. So this patient is, the first patient is chronic granulomatous disease. You see here, this is a normal person. A normal person will have NADPH oxidase. So he will be converting NBT into formazole and will be showing this blue color. So he is a normal person. Okay. Now moving on to the next question. After an incised wound, new collagen fibrils are seen along with growing epithelium. What is the age of the wound? So it is a question concerned with the wound healing process, and they are asking you the age of the wound. In the age, actually they have given us that new collagen fibrils. New collagen fibrils are seen along growing epithelium. Okay, so listen carefully. So, like, what are all the changes you can expect when a wound is there? So first, whether it can be a wound healing by primary intention, first intention, or secondary intention. The first thing is the scab formation. Scab is nothing but the blood clot formation. Yes. So when there is a blood clot formation, so what happens? The fibrin clot and the dead tissues and all will be there. So this will be replaced. Actually, this has to be removed and this will be replaced by a new tissue. So to remove that dead tissue, first cells which come there is the neutrophils. Okay. So neutrophils will eat away all these dead particles. Okay. Neutrophils will eat away all these dead particles. So what happens? The neutrophils will be clearing the fibrin clot and the dead tissues. So whatever the remaining part which is left over, then there comes actually macrophages. The macrophages will try to remove the dead neutrophils and the remaining dead over tissues. So all the dead areas are now cleared. So that area has to be united. Yes. Now the raw area is there. Now both the raw area has to be united. So you need a special tissue like which should act as a cement-like substance, which should act as a cement-like substance which unites the two raw areas. That cement-like substance, that tissue is called as the granulation tissue. That tissue is called as the granulation tissue. So granulation tissue, what will be there? Lot of macrophages will be there, and you will be getting a fibroblast cells. What is the function of this fibroblast? These fibroblasts are the cells which produce the collagen. The fibroblast only will be producing collagen. Like after this, like anything will need any plant will need a blood water supply. No, similarly, the tissue, any tissue to survive, it needs a blood supply. So new blood vessel should be there because that area was already damaged and dead and removed. No, there was no blood supply. Now new blood supply has to be established, and that will be called, that process is called as angiogenesis or neovascularization. So new capillaries will be sprouting in that area. So after some time, if you see, there will be a scar tissue will be more formed and there will be fibrous unit. So this is the thing which is happening both in case of a wound healing by first intention and second intention. Yes, now you know that what is wound healing by first intention. It is a clean wound like a surgeon makes in the operation theater. It's a clean wound, uninfected wound where there is a minimal loss of tissue. Then what is the wound healing by secondary intention? Where it is in, imagine a case of a road traffic accident where there is a chance of infection and a large amount of tissue is removed. That is wound healing by a secondary intention. Yes, the phenomenon occurs both same in both primary and secondary, but the scar tissue, granulation tissue, etc., all these things are more pronounced in case of secondary intention, and complications are also more common. Okay, so now to solve this MCQ, we have to know the timeline. We have to know the sequence of events which occurs and also the timeline which occurs in this case of wound healing. So in the day zero, that immediately after the wound, what you will be getting, like as I told, you will be getting fibrin and a platelet to form clot formation. Yes, you will be getting fibrin clot formation. After that, what happens? I told the neutrophils will be coming. So the first cells to come there is the neutrophils. The first cells to come there is the neutrophils. That occurs in one. So day three, what happens? Macrophages, neutrophils will be replaced by macrophages and early granulation tissue occurs. Early granulation tissue occurs. So in the early granulation tissue starts at the, day three. And in this, please remember, this is a very important point. Collagen type 3 will be deposited in the margins. So collagen type 3 first visible at the granulation tissue and that is at the day 3. Day 3. So it is at the margins. So day 5, what happens? There is a maximum granulation tissue and there is a bridging of the incision gap and the full epithelialization occurs. And day 14, there is a maximum collagen deposition and actually there will be edema, WBC, all these things will be removed. And in the fourth week, the collagen type 3, remember this is the initial type of collagen formed is type 3. So this type 3 collagen will be replaced by collagen type 1. Type 1. So coming back to the question here, at actually new collagen fibrils, when it is formed along the growing epithelium, you know that it is the third day only the early granulation tissue occurs and the new collagen fibrils are formed. So we are searching for the third day. No, it is 4 to 5 days and about 1 week. This is not there. 12 to 24 hours, it is not there. So third day, the option fits is 24 to 72 hours. So the correct answer here is the 24 to 72 hours. Yes, let us move on to the complications of wound healing. So what is this? If a wound is not healed and you get this reddish area, what is this thing called as? See, granulation tissue, if it is not there, then also the wound will not heal. If there is excessive granulation tissue, then also the wound will not heal. See this is actually these are all this reddish one. No, these are all the excessive proliferating blood vessels. And these are all the, what is this finding called as? What is this complication called as? That is called as proud flush. This is called as proud flush. So proud flush is nothing but the excessive granulation tissue, which is preventing the wound healing, Okay. Now coming back to these two complications, yes, all of us are very well known about these two complications. Yes, which is keloid here? Out of this, which is keloid? One scar is growing along the margins, yes, along the margins and just raised. See here, but here the scar is going above the margins and it is irregular in shape, and this is the keloid. And this is the hypertrophic scar. What is the important point you have to know between these two things? And a hypertrophic scar can regress. Hypertrophic scar can regress, but keloid will not regress. Okay. What is the commonest site for keloid you will be remembering? It is the ear lobule, sternum, all these are all the common sites for keloid formation. Keloid will also have a genetic basis. Okay. So remember all this. So in the histology, you can see for histology of a keloid, you can see the lot of collagen fibers. See this, the collagen fibers, how they are arranged, haphazardly they are arranged. See this. So one fiber is going like this, other fiber is going like this, other fiber is going like this. So other fiber is going like this. So there is a haphazard arrangement. Okay. Haphazard arrangement of the collagen fibers. If you can see in a keloid, haphazard arrangement of collagen fibers is seen in your keloid. This is a very important question in keloid. Now moving on to the next question. A 65-year-old male with a prior history of rheumatic heart disease was found dead in his home and thought to be brought to the hospital by the neighbors. Autopsy was performed and a red mass was found in the dilated left atrium of his heart. Microscopic image of the histopathological section of the mass is shown below. Which of the following best describes the finding in his left atrium? Yes, what do you think about this? See the image carefully and give me the answer. So the patient is having, yes, very good. The patient is having a rheumatic heart disease and is found dead. So autopsy is doing, they are getting a red mass in the left atrium, dilated left atrium. This is a very important point, dilated left atrium. This rheumatic heart disease would have caused a mitral stenosis and dilatation of the left atrium would have occurred. So what you can see in this picture is, you can see alternating, yeah, very good, very good. You can see red lines, these are all the red lines and these are all the white lines. So alternating red and white lines, alternating red and white lines. These lines are called as lines of Zahn, lines of Zahn. And lines of Zahn are characteristic of a thrombus. Lines of Zahn are characteristic of a thrombus. Okay. So the option here is the antemortem thrombus. So let us explore the other things. So one more thing, they have highlighted the word, I have highlighted the word dilated. Why it is dilatation? Because you know Virchow's triad. Virchow's triad. What is the Virchow's triad? Endothelial injury, hypercoagulability, and altered blood flow. Altered blood flow. Altered blood flow means it can be either a stasis of your blood or it can be a turbulent blood flow. It can be a turbulent blood flow. Okay. So our dilatation of the blood vessel occurred here where there is a stasis of the blood has occurred, and that is the predisposing factor for the clot form, thrombus formation. Okay. Thrombus formation. Then another thing, what is this thrombus formation in the chambers of the heart is called as? Yes. If you see thrombus formation, see this. This is the left ventricle is dilated in this case, and there is a thrombus formation in the chambers of the heart. What is this condition? What this thrombus is named as? What is this thrombus named as? If you see this thrombus formation in the chambers of the heart, like in the left ventricle or in the left atrium, what is the special word you call that? You call it as a mural thrombus. Mural thrombus. So mural thrombus is nothing but chambers of the heart will show the thrombus formation. Thrombus formation. Okay. What is the thrombus seen in the valves? Yes, these are all the vegetations. So these are all the vegetations. Vegetations are nothing but a sort of thrombus formed on the valvular surfaces. Valvular surfaces. Yes, this image will show you about the gross appearance, the similar red and white appearance of the lines of Zahn. Yes, if you can see this kind of a solid mass, and what you can call this as, yes, you can see here one area is appearing as a yellowish in color, and the other area is appearing as a reddish in color. What is this thing? What is this thing? Alternating this, see, yellowish in appearance. Yes, chicken fat appearance. Very good. This is called as a chicken fat appearance because it is yellowish in color. And What is this reddish in color? This area is called, this is called as red currant jelly. Red currant jelly appearance. Red currant jelly appearance. So if you can see this chicken fat appearance and red currant jelly appearance, you will think of a postmortem plot. Okay, you can't call that as a postmortem thrombus, Mohan. You have to call this as a postmortem plot. Okay, so like please understand the difference between a clot and a thrombus. Clot can be formed antemortem or postmortem. Clot, the blood clot, it is nothing but a blood clot. Blood clot can be formed in a live tissue or in a dead tissue. But thrombus is formed only in a live tissue. Thrombus is formed only in a live tissue. Because of that thrombus in a live tissue, then only it is getting this alternating white and red lines, that lines of sun. So please remember, antemortem thrombus. Antemortem thrombus will have lines of Zahn, whereas the postmortem clot will not have lines of Zahn, because after means postmortem clot, this clot are formed after death only. So after death, what happens? The circulation stops. So the circulation stops in the blood vessel. So the blood settles, the cellular compounds, that is the RBC, settles at the bottom of the vessel. And what is remaining in the superficial part? That is the yellowish plasma and containing fibrin and other proteins. So that yellowish part occurs at the topmost thing. That is the reason why you are getting two layers. You are getting chicken fat appearance and you are getting this red currant jelly appearance. No, the chicken fat appearance is the superficial part where you get that yellowish material, that is the plasma proteins and those things. And the bottom part is the settled RBC by gravity. So postmortem clot will have chicken fat appearance and red currant jelly appearance, whereas antemortem thrombus will be having lines of Zahn, lines of Zahn. Okay, this is a very important point. Okay. And a few important differences between an arterial thrombus and a venous thrombus also you should know. Arterial and venous thrombus. And what is the main important feature to differentiate this arterial and venous thrombus? Arterial thrombus are mainly because of an endothelial injury. Okay, it is because of an endothelial injury. Whereas venous thrombi is because of a venous stasis. Okay, it is because of a stasis. So the arterial thrombus, the lines of Zahn and all this thing will be, and actually this is also called as a pale thrombus. Pale thrombus, pale thrombus. What do you mean by pale thrombus? It contains a lot of platelets and fibrins. It contains lots of platelets and fibrin. Whereas venous thrombus is called as a red thrombus. So red thrombus means it is clear that there are more of RBCs. There are more of RBCs will be there. More of RBCs. Which one will be friable? Please remember, venous thrombus is more friable. Venous thrombus is loosely adherent. Venous thrombus is loosely adherent and firm in nature, loosely adherent and firm in nature Whereas arterial thrombi is firmly adherent and but friable, firmly adherent and friable. How will you remember this thing? Please remember, loosely adherent. So venous thrombi, the thrombus which is occurring in the deep vein thrombus. Yes, the thrombus which is occurring in the deep vein thrombus can be easily detached from the deep leg veins and they can result in the pulmonary embolism. No, so the pulmonary embolism is commonly caused by the deep leg vein thrombus. No, so the deep vein thrombus, venous thrombosis, are actually loosely adherent to the vessel wall, and easily they can detach and result in pulmonary embolism. Whereas the arterial thrombus are firmly adherent. But consistency wise, if you touch a venous thrombi, they are very firm, whereas the venous arterial thrombi is friable. So actually, please remember this friable thrombus can form as an embolism and can result in a ischemic manifestation. So this is very important point you have to remember. Moving on to the next question. A 68-year-old man with ischemic heart disease and a history of smoking, complaints of increasing shortness of breath, On physical examination, the patient has a swollen leg, an enlarged liver, and a fluid in the pleural space. Which of the following hemodynamic disorder explains the pathogenesis of hepatomegaly in this patient? Yes, what was your answer? The patient is having ischemic heart disease, and there is a history of smoking. From the history of smoking, there is a shortness of a breath. Patient has edema, enlarged liver, hepatomegaly is there, and pleural effusion is there. So all this points towards a, yes, you are right. All of you are right. So all this points towards a case of a cor pulmonale. What is cor pulmonale? That is a lung disease. Why there is a lung disease? See here, he is a patient of a chronic smoking. And the chronic smoking with increasing shortness of breath, increasing shortness of breath. So the chronic smoking, cor pulmonale would have set in. Okay, lung disease causing a right heart failure. So right heart failure, you know that right heart failure, usually you will be getting CVC, liver and CVC, spleen, all these things you will be getting in right heart failure. Okay. And hope you remember from our class that actually left heart failure is seen in CVC lung. Okay. Left heart failure results in CVC lung. Okay, so here they are asking you the pathogenesis of a hepatomegaly. So why there is hepatomegaly? Because there is a congestion occurring here. The right heart is failed. So right heart is no more receiving the blood supply from the systemic veins. So there is a congestion which occurs, and this results in the chronic passive congestion, that is a CVC liver. Yes. When I tell you the word CVC liver, you will simultaneously remember this picture. So what is this picture? This is nothing but this is the classical, all of our famous nutmeg liver. Nutmeg liver. So what is this nutmeg liver? So nutmeg liver, you can see in the cut surface of the spleen, you can see dark reddish spots. Okay, you can see this dark reddish spots alternating with the pale viable areas. That is the viable tissue, viable tissue. So this appearance is called as a nutmeg liver. This appearance is called as the nutmeg liver. So this is the nutmeg. Like you can see the cross section of a nutmeg, and the liver in CVC liver, we can get this sort of nutmeg appearance, nutmeg appearance. So why this nutmeg appearance occurs? Because you can see here in the central vein, in CVC, what happens in the central vein, that is in the hepatic vein, there is congestion occurs. So here the vein is getting congested. The vein is getting congested. So the hepatocytes surrounding this congested vein, the hepatocytes surrounding this congested vein will be going in for this area. This area will be going in for hemorrhagic necrosis. This area will be going in for hemorrhagic necrosis. Whereas the peripheral area, this area will continue to get the blood supply from the portal triad. In the portal triad, we have hepatic artery, no? So the hepatic artery will continue to give the blood supply to this part of the liver. So this part of the liver. So here, this part of the liver will get the blood supply, and this part there is hemorrhagic necrosis. So you can get alternating red and viable area. Red indicates that the areas of hemorrhagic necrosis, and white indicates that pale area indicates that it is a viable tissue. So only you are getting this CVC liver nutmeg appearance, okay. And what is this thing? Yes, what is this image shows you? This image is telling you like a lot of alveolar spaces or the alveolar space. So with this alveolar spaces, you made a diagnosis of this is a lung. So now we are talking about a CVC. So it should be a CVC lung, and you are searching for the characteristic finding in CVC lung. Yes, you have got this CVC lung, the characteristic finding. What are these cells called as? What are these cells? Characteristically cells. That is, these are all the macrophages. What are these cells? These are the macrophages which have engulfed the RBCs, which have engulfed the hemosiderin. Okay, hemosiderin. There is a chronic congestion is there, no? Yes, these cells are called as heart failure cells. Very good, very good. Heart failure cells, very good. These heart failure cells are seen in CVC lung, heart failure cell, CVC lung, which have engulfed the macrophages. Okay, which are the macrophages which engulf the hemosiderin. So CVC lung, left heart failure. And if I say that this is a source of calcium, Like usually I insist, no, like if in a histopathology, if you see lot of bluish material, you can first think of a calcium. See this is a calcium, and there is a congestion which is occurring here. So this is a case of a spleen. So spleen, there is calcium deposits, plus there is a fibrosis. There is a fibrosis occurs, and there is a siderosis occurs. There is a siderosis, that is a hemosiderin deposition. There is a hemosiderin deposition that is called as siderosis. So these bodies are called as sclerosiderotic bodies. Sclerosiderotic bodies. Sclerosiderotic bodies. So in CVC spleen, where does the congestion occurs? In CVC spleen, the congestion occurs at the red pulp. The congestion occurs at the red pulp. Yes, all of you know that the CVC spleen occurs in right heart failure. Yes, very good. Sclero, that is a fibrosis occurs. Siderotic is there. Plus calcium. Yes, so these bodies are called as Gamma-Gandhi bodies. Yes, it is not gamma, it is called as Gamma-Gandhi bodies. Very good, very good. Gamma-Gandhi bodies. Okay, and one more thing, what type of calcification occurs this? So CVC spleen, what type of calcification? Dystrophic or metastatic? So CVC spleen, it's a degenerative change. Okay, chronic venous congestion. So it is a dystrophic calcification. Very good, very good. Dystrophic calcification. Now, moving on to the next question. A 14-year-old boy has developed multiple nodules on the skin over the past 8 years. He also has a light brown macules on the skin of the trunk, and a slit lamp examination revealed pigmented nodules in the iris. One of his siblings and a parent have a similar manifestation. Which of the following inheritance patterns is most likely to be present in his family? In this family? Yes. So the history tells you that for a child, a 14-year-old boy, and with a multiple nodules of skin, the skin shows multiple nodules, and it is for their 8 years. And he is also having a light brown macule. So what are these macules? These macules are the cafe or lay spots. Yes, these macules are nothing but these macules are the cafe or lay spots. And this pigmented nodules in the iris, that is the nothing but the eyelash nodules. Okay, that is the leash nodules. Leash nodules, very good, leash nodules. So this condition is a neurofibromatosis. So all of us know that neurofibromatosis is a autosomal dominant condition, autosomal dominant condition. But what we have to recollect and what are all the questions we have to be very prepared for INCT, it is that the examiner can give you a pedigree chart, and we have to be able to interpret all the pedigree chart of all the modes of inheritance. Yes, should we have a quick recap of those things? Yes, see here, what is this type of pattern of inheritance? See this, every generation, first generation, second generation, third generation, every generation, at least one person is affected. Okay, every generation, the patients are there. Okay, so there is no skipping of the generation. There is no skipping of the generations. And also please note down, it is both males and females are affected. No gender preponderance. Okay, no gender, and every generation one person is affected, no skipping of the generation. So this type of inheritance is called as autosomal dominant. Autosomal dominant. Yes, quickly recap about all the autosomal dominant. You know the mnemonic. Yes, that is a very powerful dominant. Yes, the mnemonic, very powerful, famous mnemonic, very powerful dominant H. Yes, this is the mnemonic for this to remember your autosomal dominant conditions. Von Willebrand, von Hippo, and don't worry, I'll share this PDF with you all so that you can note and make a note of these things, and you can read and revise these things. Okay, dystrophia myotonica dominant, osteogenesis imperfecta, Marfan's, very repeat question, porphyria, intermittent porphyria, and neurofibromatosis, our question. Achondroplasia, adult polycystic. Please remember, adult polycystic kidney disease is autosomal dominant. Okay. And autosomal recessive is the infantile polycystic kidney disease. Noonan syndrome. Okay. Dominant tuberous sclerosis. Then H. All this H. hypercholesterolemia, Huntington, hypertrophic obstructive cardiomyopathy, hereditary spherocytosis, HNPCC, HHT, hereditary hemorrhagic telangiectasia. All these are all autosomal dominant. Okay. Then, what is this pattern of inheritance? Both males and females are affected. Yes, females are affected as well as males are affected. But very important thing is actually there is a skipping of generation. There is a skipping of generation. So skipping of generation. Then how the disease would have occurred here in these patients? These patients, they would have got a horizontal inheritance. Horizontal inheritance. So in autosomal dominant, it was a vertical inheritance, whereas this condition is a horizontal inheritance and there is a skipping of generation. So what is this pattern of inheritance? There is skipping of generation. See, this generation nobody was affected, this generation also nobody was affected. So then how these persons would have got the disease? These persons would have got the disease by actually during that marriage, that horizontal inheritance they would have acquired this thing. So what is this type of inheritance? Yes, it is autosomal recessive. It is autosomal recessive. Yes, let us recollect what are the autosomal recessive disorders. You remember the mnemonic A, B, C, D, E, F, G, H? Yes. Albinism, ataxia, alkaptonuria, alpha-1 antitrypsin deficiency, beta thalassemia, cystic fibrosis. Yes. Distal spinal muscular atrophy, Dubin-Johnson. This is all in a workbook also. Okay. So emphysema, Friedreich ataxia, galactosemia, glycogen storage, hemochromatosis, homocystinuria. Please remember, all the inborn errors of metabolism, all the inborn errors of metabolism are the autosomal recessive, except your Hunter's disease, okay? And G6PD deficiency, they are X-linked recessive disorders. Yes, X-linked recessive disorders. Now, this is the famous inheritance, and all of you know that. See here, the females are carriers. See this pattern of pedigree chart. The females are carriers and the males are affected. The females are carriers and the males are affected. So this kind of inheritance is called as X-linked recessive inheritance. X-linked recessive inheritance. The affected female is not there. Only the affected male is there. Okay. So the but the affected male will not transmit the disease to the male. See, the father is affected here. The father is affected here, but the child, the daughter is not getting, the daughter is a carrier and the son actually, see this thing. The son actually he is not giving, but a carrier female gives the X chromosome to the son. So the son is getting affected. Okay. Because it is a X-linked. Father gives only Y chromosome to the son. Father gives only Y chromosome to the son. So father will not transmit the disease to the son, but a carrier female will transmit the disease to the son. So this pattern of inheritance is called as X-linked recessive. Yes. So X-linked recessive or the Lesch-Nyhan syndrome, hemophilia Hunter, chronic granulomatous disease. We have seen no NADPH oxidase, then G6PD, Duchenne muscular dystrophy, color blindness, A-gamma globulinemia, Fragile X syndrome, Biscott-Aldrich syndrome. You also will remember a mnemonic, no? Lady Hardinge college girls. Lady Hardinge college girls don't care about foolish words. This is a famous mnemonic, no? To remember your X-linked recessive disorders. Yes. Lesch-Nyhan, hemophilia, all these things are important. Okay. Then coming back to next type of inheritance, see this, both the